Thanks very much. Thanks for sticking around. Thanks for being here, and thanks for the invitation to speak. Can I just get by a show of hands GPs in the room? Great. So I'm speaking to probably mostly GPs, pharmacists? Some pharmacists as well. Okay, perfect. One more show of hands. Who has heard of pharmacogenetics? All of you. Amazing. Okay, that's great news. Can we get the slides up, please? Thanks. For most of my career since starting, or since finishing my PhD, we were focused very much on the personalized medicine aspect from more of a wellness perspective. So nutrition, diet, lifestyle, that type of medicine. But I always felt that pharmacogenetics represented the ultimate adoption of the concept of personalized medicine, because it's something that is relatable to so many people, and conceptually something that everybody can understand. We've all had a conversation with our friends about taking a particular medication and saying that, guys, it's the wrong side. I'm not talking on this. We've had that conversation with people where we say how, you take one Panado maybe and it puts you to sleep. Another one says, well, I'll take 4 Panados and it does nothing for my headache. And so conceptually, the idea that we all respond differently to different medications is one that is not a difficult concept to understand. The amazing thing now is the field has advanced to the point where we have the science to understand the concept and to provide the evidence for why we should be adopting a more personalized approach to the way that we script. Sorry, just got to work this out now. Right. So for those of you who don't know or haven't come across the term, what is pharmacogenetics? It's a combination of pharmacology and genetics, and is concerned with the inter-individual variation, inter-individual metabolic and therapeutic responses to a given medication. We're looking at genetic variations which can affect an individual's response to drugs, both in terms of therapeutic effect and perhaps more importantly in relation to adverse reactions. Furthermore, we're aiming to identify additional genetic biomarkers that affect drug response and use them to make better drug therapy decisions for everyone. So that's a bit of a mouthful. We simplified it a little bit. We say pharmacogenetics is a field of research that studies how a person's genes affect how she or he responds to a particular medication. The goal is to enable doctors to make better treatment decisions by helping them to select drugs and dosages best suited for each individual. I often use the example of psychiatry, which I think most of the feedback we get from the psychiatrists is how it's just a black box, a trial and error approach to prescribing. And we've all heard the story of patients going to a psychiatrist, being given a particular drug regimen, and they're told, come back in 6 weeks and let's see how you're doing. And if they're not doing well, they change it or adjust the dose or maybe add in a new drug, come back in 6 weeks and see how you're doing. With a tool such as pharmacogenetics, the idea is to narrow the number of options that psychiatrist would have by knowing in advance where there's likely to be a lack of efficacy, where there's likely to be a risk for a side effect, and to just narrow the options. We can't do the job for them, we can't diagnose for them, and we can't tell them categorically what to prescribe, but we can attempt to make that job a little bit easier. And just for the record, I hate the word pharmacogenetics. Nobody understands it, nobody can say it, and it really is an awful mouthful of a word. So I just prefer referring it to as precision prescribing, which is something that just makes the whole term a little bit more understandable. And here we have the typical diagram illustrating the concept of pharmacogenetics, where you've got a typical one-size-fits-all blockbuster approach to drug development. One medication is given to every individual. And it's all very well when you get told that a trial shows a medication is 99% effective, unless you're that one. And that's where medicine is going, is N equals 1. It's all about the individual. It doesn't matter that 99 other people do fantastically on it. If you're the one who has a severe adverse reaction or complete lack of efficacy, then what happens to the other 99 people doesn't really matter. Personalized prescribing enables selections of the right drug and the right dose. So you split this group of 4 people into 4 different cohorts, where one of them gets the standard medication, One of them might get a reduced dose, one of them might get an increased dose, and the fourth might get a completely different medication altogether. Just as an aside, maybe a personal story which you might find interesting, and which is why perhaps I'm so passionate about the concept of pharmacogenetics. I had a kidney transplant in October last year from taking anti-inflammatories that were prescribed for back injury about 20 odd years ago. So taken according to script, not abusing them, not eating them like Smarties, following the script, and the anti-inflammatories messed up my kidneys. So I was fortunate enough to find a donor. It was hugely successful, but it's just one of these stories that you tell to emphasize that that kind of side effect can happen to anybody. And often you just have simply no idea that it's happening until it's, well, not too late, but until the damage has been done. So why is it so important? What is the burden of adverse drug reactions around the world? And just to note, these are statistics out of the US. In South Africa, it's a lot more difficult to get accurate statistics because of the poor reporting and the poor tracking of adverse reactions. But the numbers are quite frightening when you look at the US and you assume the numbers are not going to be that different in South Africa. So it's one of the leading causes of morbidity and mortality in healthcare. Studies estimate that 6.5% of hospitalized patients have a serious adverse drug reaction with a fatality rate of 0.32%. That translates into more than 2.2 million serious adverse drug reactions in hospitalized patients, and over 106,000 deaths annually in patients who go into hospital for something completely unrelated and end up dying from the medication that they've been given. This overall makes adverse drug reactions the fourth leading cause of death in the US, ahead of pulmonary disease, diabetes, AIDS, pneumonia, accidents, and automobile deaths. So there's sort of a standing joke, maybe not amongst the doctors, but amongst the scientists, that says doctors are the fourth leading cause of death in the US. Maybe it should be the pharmaceutical companies and not the doctors. So I'm sure most of you are familiar with the cytochrome P450 family of enzymes. It's one of the largest family of enzymes responsible for metabolizing. Numbers vary a little bit, but it's around 50% of all drugs in clinical use go through one of the approximately 50 members of the cytochrome P450 family. So a hugely important gene and enzyme family when it comes to metabolizing prescription medications. I'm going to focus in specifically on one of the genes within that 450 family, which is cytochrome 2D6. This enzyme is responsible for the metabolism of many commonly prescribed drugs, including antidepressants, antipsychotics, analgesics, and beta blockers. It's one of the most variable of all the cytochrome P450 genes. There are more than 135 distinct variations that have been identified within the gene structure. So when we talk about variations in the gene structure, we're looking now at the DNA level of the gene that makes the enzyme, that makes the protein. And there are all of these different genetic variations within that DNA code. The combination of those variations that you have will determine the eventual haplotype, which is what we call the combination of different genetic variations, which then be converted to determine the metabolizer status of an individual, which is the phenotype, the physical manifestation of your genetic code or your genotype. The prevalence especially of gene duplications, where the entire gene has been duplicated within the genome, or gene deletions, where the entire gene is absent from the genome, is especially critical to the functioning of the enzyme. And while laboratories reporting a CYP2D6 status absolutely need to include copy number variation analysis when putting out their report. I'm going to go a little bit into the science here, just to give you an idea of what these structural variations look like within the DNA. So if you can picture each line as being a stretch of DNA, you've got your 2D8 over here, then your 2D7, there's another marker there, then you've got your CYP2D6 gene, which is this rectangle over here. That is the reference locus, which is called the wild type, and that is the one that's going to be most prevalent in the population, which is your normal version of the CYP2D6 gene. In B over here, you can see that entire CYP2D6 gene has been deleted. And in C, you can see now that there are duplications, either just 2 copies, or in some cases, multiple copies of that CYP2D6 gene. And the number of copies determines then the amount of enzyme that gets made and determines how quickly you're going to break down the different medications. So let's look at what that does when a medication is given and you've got these different metabolizing speeds of that medication. So when an active drug is metabolized by a cytochrome P enzyme, loss of function of the enzyme will increase the effective serum concentration of the active drug. Therefore, the patient will be at risk of side effects. So as you can see here, you've got, let me just take you through this nomenclature. You've got poor metabolizers. These would be where there's a deletion and you've got loss of function. Increased metabolizer, where there's maybe a decreased function, but you've still got some function. Your normal metabolizer, your reduced metabolizer, and your ultra-rapid metabolizer, where you've got multiple copies of the enzyme. Now, ideally, as you know, you want that medication to be within the therapeutic window for as long a period of time as possible. As you can see, with the poor metabolizers, the medication, the drug, does not get broken down to its active metabolite until very late in the process. And that's where you've got risk of the medication sitting around in the serum, potentially causing side effects. And conversely, on the other side of the spectrum, you've got the ultra-rapid metabolizer, where it's broken down very quickly, it never reaches the therapeutic window, and then you have a complete lack of efficacy. Now, this is just one example. When you've got an ultra-rapid metabolizer, it doesn't mean it's always going to be a lack of efficacy. Because if you take a drug, and I think I'll go into it here. Yeah, we'll get to that just now. Just as an example, a drug like codeine is a prodrug, which is broken down to its active metabolite, morphine. Now, in the case of codeine, if you've got an ultra-rapid metabolizer, it's breaking down that codeine much too quickly, and so you actually get elevated levels of morphine in the blood, and that's where you get the side effect of toxicity, morphine poisoning. And there have been instances, as I'll show you later, where infants have died through breastfeeding when a mom has been taking codeine. And that's why there's a black box warning on codeine that it's not suitable for kids under the age of 12, and in many cases it's actually been banned completely. You might think that these variants are incredibly rare in the population, and that what I'm talking about is something you'll barely ever see in practice. In actual fact, they're surprisingly more common than what you might think. So what we've got here are the normal functioning alleles, which, as you'd expect, make up the bulk of the population, approximately 50 to 55% of your population. And this is across multiple population groups. If we narrow it down to African population, for example, your normal metabolizer is only 50% or just under of your patients. And a significant number are going to have decreased or no function alleles. Right? So almost 50% of the patients who walk into your practice are going to have a alternatively functioning cytochrome P2D6 enzyme. You've got your increased function, your gene duplications making up around 5%, and then decreased functional alleles together probably around 45%. So this is not insignificant in terms of the number of times you'll see it in practice. If we look at the European population, it's a little bit higher on the normal metabolizers, just over 60%, but now your loss of function alleles is upwards of 20%. So 1 in 5 patients that walk into your room will have no functioning allele in CYP2D6. And these are the guys who are, the CYP2D6 enzymes, as I said, are responsible for metabolizing about 50% of all drugs in clinical use. So it really is an incredibly important thing to understand about your patient before summarily prescribing the preferred medication. And it might change your whole idea about what that preferred medication might be once you take genetics into account. I did allude to codeine earlier. Here we just see the pathway where CYP2D6 is responsible for breaking it down into morphine, and the ultra-rapid metabolizers will end up with elevated levels of morphine in the blood. Conversely, with codeine and your CYP2D6 poor metabolizers, that's where you're going to get the lack of efficacy, because codeine is not going to get broken down to the active morphine metabolite, and so they're simply not going to respond to that codeine medication. So this is just the article, the case I mentioned briefly about a morphine poisoning in a breastfed neonate of a codeine-prescribed mother. There have been similar cases where post-tonsillectomy or adenoidectomy, infants have had, or kids up to the age of 9 or 10 have had severe side effects from codeine as a medication. And in the package insert of codeine, it recommends testing for CYP2D6 metabolizer status before prescribing the drug. And in fact, what you might be surprised to know is that that similar warning, not just about CYP2D6, but about multiple enzymes, appears in the package insert of over 200 medications. When was the last time anybody read a package insert? Right. So that's why we have these conferences, so we can make life a bit easier. Just showing you how this type of thing is reported within the scientific tables. There's a group called the CPIC, which is the Clinical Pharmacogenetics Implementation Consortium. What they've been doing is they've been collating all of the research, all of the evidence for the association between different genes and drugs and assigning evidence levels to those associations to determine whether it's appropriate or there's sufficient evidence for their use in clinical practice. So what we've got here is the codeine therapy recommendations based on CYP2D6 phenotype. For the ultra-rapid metabolizer, avoid codeine use due to potential for toxicity, consider other alternative analgesics. You give morphine directly, because if you give morphine directly, you don't need CYP2D6 to metabolize the codeine. So giving morphine would be the more appropriate intervention there. Similarly, with the poor metabolizer, avoid codeine use due to a lack of efficacy. Again, you can consider morphine directly. Just one or two additional medications that you might prescribe, or maybe if you refer patients to psychiatrists who might prescribe. You've got amitriptyline, where it's metabolized through CYP2C19. Again, you've got ultra-rapid metabolizers of CYP2C19, where you'd avoid tertiary amine use altogether due to potential for suboptimal response. So, and your poor metabolizer, similarly, you're avoiding tertiary amine use. There, what CYP2C19 is doing, it's balancing the ratio of the tricyclic amino acids within the blood as it gets broken down. So you end up with out of balance blood levels of the different TCAs associated with amitriptyline and its product nortriptyline. So you're going to avoid tertiary amine use. If you do want to recommend it, if you can see down at the bottom here, it's telling you to consider a 50% reduction of the starting dose. So it's not always a question of simply saying, don't use the medication. It might be that you can increase the dose, you can decrease the dose, but just you've got the tools to be aware of what that prescribing decision should ideally be. And similarly with sertraline here, we've got CYP2C19 per metabolizers. You're going to again have a 50% reduction of the recommended starting dose. So in summary, with pharmacogenetics and drug metabolism, individual differences in the expression of a protein or enzyme may affect the absorption, distribution, metabolism, or excretion of a drug. These effects could lead to changes in the level of the active drug metabolite, possibly being harmful and warranting the use of a different drug or a different dose of the drug. As I mentioned earlier, there are approximately 200 drugs with FDA-approved pharmacogenetics-guided dosage information in the package insert. There are also certain vulnerable patients that are particularly good candidates for pharmacogenetic testing. So who could benefit from a test like this? Anyone experiencing side effect to a specific medication? I think there used to be an approach to side effect that it was sort of a necessary evil, that it was unavoidable and it was just unlucky. You know, if you took a statin and you suffered muscle myopathy, well, it's better than a high cholesterol, so pick your poison. But the reality is that that doesn't have to be the case, and we don't necessarily have to just tolerate and accept the side effects that come with some of these medications. Then, obviously, anyone who's not responding to a specific medication, you know, that's when you embark on this trial and error approach, by seeing that they're not responding and saying, okay, well, let's try this, as opposed to, well, let's do a DNA test and ascertain what you would respond to, or what you most likely would respond to. Anyone requiring dosages outside of the recommended range, where the dose has been upped and upped and upped. And actually, I mean, it sounds like I come from a family of pharmacogenetic candidates, but my wife, after she had my second child, she developed a venous sinus thrombosis. they titrated her warfarin dose for about 10 weeks before they eventually changed the medication. Unfortunately, we didn't have the test in the lab at that point, but she was the first person I tested when we did get it, and she was a non-responder to warfarin, and they would have probably, her starting dose would have probably been where they got to after 6 or 7 weeks, if we'd had that information up front. For 8 or 10 weeks, she's walking around with a venous sinus thrombosis, well, not so much walking around, but, it's there, and just simply not responding to the medications. That's clearly a candidate for when you would do a pharmacogenetics test. Anyone planning to start on a new medication? I mean, all the time, people are starting on new medications that they're potentially going to be on for the rest of their lives. I think it is incumbent on doctors who now have some of these tools at their disposal, and patients who are becoming more aware of these types of tools, to make sure that if we're going to put somebody onto this medication, it is going to be working. One of the examples I didn't show today, but Plavix is commonly prescribed for patients who've had a cardiovascular event, such as myocardial infarction. 10% of the population do not respond to Plavix. And there's no way of knowing that until the next cardiovascular event. And so, that's how I convinced the cardiologist I was speaking to when he did his own test, and he realized that he was not responsive to Plavix. He suddenly realized that all of the patients he didn't see again were either it was working or they were dead. It's pretty much the way he put it. And then you've got, I think, a good population group for testing, which is the aged, because there we're looking at polypharmacy, we're considering drug-drug interactions, we're considering some of the side effects associated with these medications are also associated with aging. Being a little bit unsteady on your feet, or a little bit of dizziness, or vision going. Those are the same as some of the side effects that the medications might be giving them. And so the side effects are often being confused for simply the fact that the person is getting older. So for the pharmacists out there, we're already looking at drug-drug interactions. The next logical step is to bring in the gene-drug interactions as well. So given that the science has been around for a while, and when I say a while, pharmacogenetic testing, there have been hospitals and clinics in the US who've been saying they will not admit a patient before they have done a gene test, and that's going back 5-6 years. So this has been around globally for a long time. It's not new science. Unfortunately, in South Africa, we seem to always be a little bit behind the rest of the world. But this is where things are going, and it's been around even in South Africa for a few years now. So given that the science is so good, what are the challenges? Why are we not seeing the widespread adoption of pharmacogenetic testing into practice? And there was a global survey that was done which highlighted some of the biggest challenges, and then I'll go through the last two are my assumption based on having been in the field for the last few years. So the first is insufficient physician knowledge and awareness, and I think it's a pretty fair obstacle, given that the average age of a medical doctor in South Africa, or maybe a GP or a physician, this didn't exist when you guys were at med school. How many of you did genetics at med school? It didn't exist, and unfortunately, most of the case, it still doesn't exist. So it hasn't yet gotten into the curricula to look after the future generation of doctors. Physicians are skeptical, and there's a perception of lack of evidence, and I think that's a typical case often of confusing ignorance with evidence. I think as doctors get older and maybe specialize, they're not as up to date with some of these scientific advances in their field as we would like them to be, and it's no fault of theirs. They're busy, they've got other priorities, there's golf, there's paddle, there's things to do. We can't expect them to be keeping up with the literature all the time. And it's something that, based on their training, is very much outside of probably their field of interest, never mind their field of practice. Often in the past, there have been unclear test interpretations. So a doctor would perhaps do a test, and the information in the report, it would say, needs a reduced starting dose. But it doesn't tell them what that starting dose needs to be. And I think that's the balance between how much we can actually tell the doctor in terms of doing the job for them, versus giving you the information that there is likely to be a side effect, look at a reduced dose, but at the end of the day, there still has to be some discretion on the part of the doctor as to what that dose reduction needs to be. Where the evidence is there, for example, with sertraline, they showed a 50% reduction, but that kind of precise information is not always going to be available on every medication. And so often this perception that there's unclear test interpretation, and lack of guidelines. So these kind of tests aren't being incorporated into the clinical guidelines. Most doctors follow guidelines. It's the way they were trained to practice. And so until some of the doctors see it in the guidelines, it's just something that they're not going to offer themselves. Over time, okay. And then often there's this disconnect between clinicians and researchers. And that's something that when I finished my PhD, I was very conscious of and I wanted to address. And the reason I started my company was there's this amazing evidence and this amazing scientific knowledge and literature and evidence that sits within the academic environment, but we never really, or it takes too long to see the translation of that science into clinical practice where it can actually benefit the end user, the man in the street. So that still exists, and there's still this disconnect, and the research gap is still too big. Based on my experience in doing it, I think that two other challenges for me: the reporting format. When you look at the cost of a pharmacogenetic test, and the medical aids will be quick to tell you that, you know, they'll do a cost-benefit analysis, but they'll look at warfarin, which is the cheapest drug around, and so they'll say, well, it doesn't make sense to test everyone to see if they're going to respond to warfarin. But what they forget to mention or to look at is that once you've done a DNA test once, your genetics don't change. So where you've got to look at the cost-benefit of a DNA test like this is ideally it would sit in an electronic health record, and you'd have it available for the rest of your life. So it might be warfarin now, but you might be seeing a psychiatrist in 20 years' time, and you might need surgery and want to speak to the anesthetist about the analgesics or the anesthetic that they prescribe, and you've always got that report with you that they can refer to. So that's where the lifetime value comes in. But that lifetime value can't be realized if the report is sitting in a 50-page PDF that ends up on the bottom shelf of a doctor's drawer. So that's the way it's been reported up until now, and I think that's one of the biggest challenges we've seen with that widespread adoption. And then also this question of potential liability. A psychiatrist might get a pharmacogenetics report which has got information on responsiveness to an anesthetic. What do they do with that information? And I've had feedback from some doctors that they're nervous as to whether they have liability if a patient has a response to a medication that is completely out of the scope of what they did the test for, but that information is still in the report. And is that doctor liable? Maybe I should find the lawyer and find out the question from her. But it's something that has concerned some doctors that I've spoken to in the past. So what I'm going to present to you for the last few minutes is, we'll finish the CPD part of the talk now. What I'm going to present to you is what I think is a solution to a lot of these problems that we're happy to be launching in South Africa, and that you can hear more about at our stand, which I think is 812. So there's still going to be a PDF report for the doctors who want it. And the way that PDF report will be presented is to initially highlight the existing medications that a patient is taking. So that'll be upfront on the first page where it's easy for the doctor to find. So this patient's taking Lipitor. There's decreased function based on this gene, and the evidence level is CPRC and FDA. So that's the first page of the report, existing medications. Next report goes into a summary of 100 and, I think it's close to 200 medications. I think it's about 170 odd medications. And again, this is where the lifetime value comes in. So for all of these 200 medications, it categorizes them 1, 2, or 3, where there's mild or no known interaction, there's moderate gene-drug interaction, or there's a serious gene-drug interaction. And those are modified, those might change over time. So all the ones that have a green number 1, as the science evolves and more research comes out, it might be that a drug moves into a different category based on new evidence that comes to light. So that report could change over time. Every one of the medications in here is hyperlinked to dosing guidelines a little bit further on in the report, where we're telling you, again, this intermediate metabolizer for CYP26, higher plasma concentrations, consider a reduction of the recommended dose. And that's where I mentioned they're not specific. So we just say consider a reduction of the recommended dose, and the same for nortriptyline at the bottom here. So what if we could automate a lot of that decision-making job for the doctor? Put it through a software, consider not only the genetics, but the diagnosis, the kidney function, the liver function, any blood works that are relevant, That is the software that we now have available to use. So we've got precision prescribing medication management software in collaboration with Genexus healthcare systems. What are some of the benefits? It empowers the physicians to use pharmacogenetic tests, lowers that barrier to entry by automating the report interpretation process and providing all interventional tools in one place, including clear dosage guidelines. The pharmacogenetics recommendations are focused on being clinically actionable and having high evidence levels, and we've limited our report to only those that have FDA level evidence. And as that list of drugs grow, so we will add more drugs into the report. It's the opportunity to view PGX guidance alongside other factors usually covered in traditional software, such as renal and hepatic functions, drug-drug interactions, everything in one place alongside the genetics. And finally, it can also be used to identify patients that would benefit from pharmacogenetic testing. So if you've got all the other clinical data in there, it'll highlight where there is a need or a recommendation to do a genetic test for a specific medication, and you can order the test from within the software. So the two pieces of software are ReviewGX and TreatGX, which I'll just go through very quickly before showing a little video that demonstrates it, and that's how I'll end off. ReviewGX, I envisage this being used perhaps by a pharmacist to do an overall review of the patient's drug regimen, and then it generates a report that can be sent to the prescribing doctor or doctors. So it's a holistic overview of all the factors affecting drug response. It gives you de-prescribing opportunities where you've perhaps got multiple doctors prescribing similar drugs that have a similar knock-on effect, and there's opportunities for de-prescribing, especially in patients to help avoid polypharmacy, and alerts for certain combinations of medications that have safety issues. And then TreatGX, used more by the prescribing physician themselves. It's tailored medication dosing options for the patient, the ability to view on one screen how several clinically relevant factors will affect medication, condition-specific clinical features, so sorting by risk of side effects for antidepressant therapy, weight gain, sexual dysfunction, sleep issues. All of these are known side effects. You can prioritize which of these side effects you're happy to put up with based on the wishes of the patient. Maybe for a female patient, their weight gain is going to be a particular priority, and so you sort by the priority of weight gain to see which is the best drug to leave out. And it allows you to confidently find the proper medication and the correct dosage. So this is a short video. So guys, if I can ask you to just press the play button on the screen there, please. So this is your dashboard where we're signing in now to the TreatGX portal. And you've got your list of patients. We've got 2 patients loaded here. The little blue helix indicates that one patient has had their genetics done, the other patient hasn't. So we can load the patient who has had their DNA tested. But you could use it as more of a electronic health record, or we would want to try and partner with providers of electronic health records to integrate this data into one system. So here you see the conditions on the left. This person's got chronic pain, they've got depression, diabetes, post-myocardial infarction. You've got the option to add a condition if necessary. The middle column gives you more details about that. I think the screen quality is terrible on here. I don't know how much you guys can see of this. I can't see it. Can you see the screen? You can, okay. So you get to put in specific details about the condition. So some of the, if they're not ticked, it doesn't allow you to move on to the next step. So there's some mandatory information about a specific condition that you'd have to complete before it allows you to generate the report. And you can add additional conditions. You can go into the patient and adjust patient information. There you had the option to add in liver disease. We can play around with their kidney function. And then you're going to click the generate medication options. And it's now giving you these options of, in order of priority, which medications are most suitable. And this is for the chronic back pain. And you'd go through each of these at a time. It also tells you specifically what should be excluded. And there, if you saw that drop down, I think I showed again. So there we're saying we are, because of the genetics, we're reducing by 50% due to the CYP2C19 metabolism. We are reducing the selective dosage by 50% based on CYP2C9 genotype. It also then shows you potential drug-drug interactions and whether those are moderate or severe. So everything's sitting there in one place to really help the physician come up with the most suitable prescribing decision. Finally, what are excluded therapy options? There's all these medications are specifically excluded because of their genetic results for CYP2C9. And I think what I just finished off in the video by doing is generating the PDF report, which shows you the summary of these recommendations, which again, far more practical, far easier to put into a file if you want, or to send to a doctor if you want, than a 50-page PDF document. So it really becomes a summary that you can have on file and refer back to regularly in the future. So we're now generating the report, and you'll see there's a single-page PDF that reports specifically on I think we went to depression, and that's going to give you the information that you need. Not that easy to get a feel for the software in the video. We do have a demo tablet at our stand, so please feel free to come through there. You can play with the software, put in different patient conditions, and see how the medication regimen will change based on how you change the patient data.